Welcome to Frankfurt. We're here at the PROSCA 2018 conference discussing elements of prostate cancer relating to diagnosis, treatment in early stages, treatment in intermediate stages, and later stage disease. I'm joined by three of my esteemed colleagues from the UK, Amit Bahl from Bristol, clinical oncologist, Nina Tunuriu, a radiologist from the Royal Marsden in London, and Hardev Pandha, a medical oncologist from Guildford. I'm Noel Clarke. I'm a urologist with a specialist interest in oncology from Manchester at the Christie Hospital. So I'm going to start by opening up with the early stage disease, Nina, and you being an expert in imaging, we've had quite a discussion about imaging of the primary disease, prognostication, diagnostics. Tell us what you've taken from PROSCA 2018 in relation to MR imaging of the prostate in the diagnostic setting.
Well, I was happy to see that indeed people have taken on board the latest data, and the multi-parametric MRI seems to be now a recognized tool, and people are keen to use it in diagnosing prostate cancer. I've also been happy to see that we understand the limitations of multi-parametric MRI prostate, and it seems that the best way forward is indeed combination of a multi-parametric prostate with targeted and standard biopsies. Bahl means we talked about some additional tests which may take these techniques and this combination further, but I think for the time being it seems that these two approaches, combining multi-parametric MRI and biopsy, is the way forward.
And this is at variance with some of the messages we get from the UK alone, isn't it? Where there is a push to get rid of the biopsy, something which has been quite controversial. But here there's been a realization and indeed some quite vocal expression that the biopsy is critical. What's your view of that?
I will agree. No matter how much I would like to say, let's just use only MRI, I think we need to keep going and combining because there is no 100% test. But I do think the future is, as I said in my talk, fewer biopsies, but in a wiser system.
Amit, if I might come to you. Patients who've been biopsied, we had a very good discussion and some keynote lectures on biomarkers and prognostication and prediction, gene testing and so on. What was your view of Chris Evans' talk in the biomarker prediction for prognosis and treatment stratification?
Well, it was a fascinating talk, but I think what we need to be sure about is realizing what the clinical implications are. And we need to go back to the real basics as to what we are trying to address here. Now, some of the biomarkers which are being talked about regarding whether one can go into a surveillance strategy or one would need to be treated for prostate cancer were being done instead of doing an MRI scan for staging that prostate cancer, which actually from UK practice I find slightly strange, because I would do an MRI and I would direct things on biopsy based on that MRI, whether you call it targeted or saturation or transperineal biopsy, and then consider the options regarding whether the patient goes for surveillance or not. I think they are here to stay because they do have some evidence, however retrospective that may be, or might not have analyzed the whole prostate in its totality. It's probably an additional tool when you're facing an individual who's finding it difficult to make a decision as to whether to choose a radical option with the potential side effects or whether you can adopt an active surveillance strategy in that individual. So maybe in that setting, maybe also in the salvage setting, and that is where I see it as a bigger role, because it's almost learning from breast cancer with the Oncotype DX and how to refine the results of that to try and avoid systemic therapy in majority of the ladies with breast cancer, as we've just recently seen. Now, will prostate cancer be able to go that step forward? That's my aim, that's my hope, but I think we still need to remember the basics like MRI scan and basing our decisions on biopsy and multidisciplinary discussions.
And as you said, I'll come to you in a minute, Hardev. We've got some interesting questions that I want you to address in relation to genomics and things. But in relation to the use of these tests in the US and Europe, there really is a big difference, isn't there?
It's a complete difference. So in the US, as I understood it, these tests are, because multi-parametric MRI is not reimbursed in the system, whereas these tests are. Seems a little bit bizarre to me, like, that you can't do a basic test which has been proven in trials, and therefore these are being used, and if these are negative or are showing you a higher risk score, then they can justify an MRI scan. I would have gone the other way around, and so there is a big discrepancy, and maybe it is time to collect data across the Atlantic and see whether it results in differing strategies. And of course we wouldn't know the results, but at least we can get active surveillance strategies across and see.
Yeah, that will be an interesting concept, because surveillance really is not uniform. It's something I'll come back to in a minute. Hardev, there was a state-of-the-art talk by Rob Bristow about genomic risks and family risks. I mean, should we be doing genomic tests on all the patients, or some of the patients, or none of the patients?
I think the scale of that undertaking compared to the very small percentage of patients which this would include as a very high-risk group is obviously very small. So I think, firstly, something very simple and clinical, which is a good clinical history, family history, and outlining what it means to have a positive family history, rather than, for example, a patient having a father who died in his late 80s of prostate cancer versus somebody being diagnosed in their 60s and then having a brother and one other blood relative. I think that's sort of the common sense context first. So I think that would reduce the numbers considerably. But at the same time, to expand that, to look at family history of ovarian cancer, breast cancer, and really widen that perspective. So I think that's important.
And that's a really critical point, isn't it? Because not only is this a disease affecting men, which clearly it is, prostate, but it is associated with that crossover, certainly with breast cancer and the BRCA-related genes.
Absolutely, and we know the biology of the BRCA mutation and its sort of biological consequences and drugs that may be potentially useful. So it's a very specific and very important group to identify, absolutely.
So Nina, could I ask you about this surveillance thing and MR scanning? Because we are a bit mixed, aren't we, in how we're doing things. Some people scan every 6 months, some people just do PSAs, some people do repeat biopsies. Where does MR sit with that, and how good is it at surveillance?
I think that I would like to say that I'm biased. The MRI will be a good test. But, and we had this conversation all the time, we do need to work towards a quality control. And I think that's where people have this discrepancy in their attitude. Because if you have a center in which the protocol is very accurate, your radiologists are heavily trained, they do a high number of cases, then of course that center will be more trusting in MRI. You have a center in which maybe the diffusion-weighted imaging, which is the cornerstone of the protocol, is not good enough, then in those centers, you as a clinician may lose a bit your trust. So I think, to me, in order to uniformize, that's what we need to do, quality control of the MRI.
And it's interesting, in the PROMISE trial, what people tend to ignore in those results is they started off with 10 centers, all of them were quality controlled, all of them had special training, they rejected 3 and came down, I think, to 7, it might even have been 6. So that quality control is absolutely critical.
Yes, for MRI specifically, yes.
Yeah. Let me move on to the more advanced element of this. Firstly, PSA failure. Just a couple of minutes on this, Amit, because we had a good session when to step in with what when people fail after radical local treatment. What did we learn from that?
Well, the interesting thing is that we have to deal with the situation as to whether it's a failure post-radical prostatectomy or a failure post-radical radiotherapy. And clearly the idea is whether we are trying to find salvage treatment options. So is there the role for radiotherapy to the prostate bed and the pelvic lymph nodes, or should we be actually chasing oligometastatic disease and then treating the oligometastatic disease, whether we treat it once, twice, n number of times, and I think that is going to be a very sort of continuous debated point over the next few years, because some people are slightly withdrawing from the idea of prostate bed radiotherapy, because we know that results in the literature by and large show radiotherapy being effective 50% of the time. Now, radiotherapy in primary prostate cancer, in early localized prostate cancer, is effective 90% plus of the time. So that is not the failure of radiotherapy, it's the failure of targeting the right place for radiotherapy. And that is where imaging will come into play. Now, but that again is the big dilemma, what imaging do you go with? And the other thing to remember is that the knee-jerk reaction that, the PSA just goes above 0.2 and I need to do a choline PET scan when the sensitivity of choline PET is very low, below PSAs of 0.5 and some would argue even 1. And even though PSMA is better, but it's not a foolproof test. So it is always understanding what your imaging is going to give you and what that will guide your treatment strategy as.
And I think that session really highlighted the lack of good quality evidence as to what to do. Yeah. There was genuine confusion, but with a view that treatment should be reserved, systemic treatment should be reserved for a relatively small number. Now, just finally, Amit, you gave a terrific lecture on the sequencing. Really enjoyable. It's not
very usual of you to praise me like that.
Most unusual. Yes. But I'm going to ask Hardev's view of this, which is the sequencing. Now, one thing that struck me with Amit's talk was this notion that we're not giving docetaxel early enough, and we should give it right up front. What do you think of that?
No, I think Amit made quite a compelling argument, and I think the reluctance to bring it in very early is very much based on perceived patient preference, I think, more and more, and clinician preference. I mean, there's been this sense of relief at not having to give chemotherapy, which I think Amit addressed pretty much head on. And it is something to really for us to look at. We talked about potential toxicity and neutropenic issues and casualties secondary to docetaxel in one of the other talks, and certainly in our collective experience, docetaxel is quite a straightforward treatment, is well tolerated. So I think that early sequencing, I think we need some sort of guidelines and consensus, and I think what we discussed today, and Amit very eloquently put forward, was a very straightforward pathway, which was very understandable for the difference between waiting till symptomatic progression versus early radiological progression. I think that's a very, very important aspect of the timing, and I think we need to perhaps, you need to write an article about this in a very accessible form, I think, to reiterate this situation.
Fantastic. So as you can see, we've had a wide-ranging discussion on the whole spectrum of prostate cancer. There's more to follow. We've got some certainties, we have some grey areas, and we have some areas where we really need to improve our knowledge. And I think that's the purpose of bringing together an international audience, which has been done at the PROSCA 2018 meeting here in Frankfurt. I'd like to thank our experts for their expert and illuminating commentary. Thank you very much.